I'm Claudine Wong, coming to you from the San Francisco Bay Area. Thanks for joining us. I'm joined now by Dr. Suji Hamilton, who is coming to us from Atlanta, former director of palliative care, former director of medical ethics at NYU Woodhull Hospital. Dr. Hamilton, thanks so much for joining us.
Thank you for having me.
So let's talk about it. Your specialty is palliative care, and that is a very specific type of care for people. Take us through what exactly that means.
So it's a medical specialty that focuses on optimizing the quality of life and the comfort of our patients. It can really be implemented at any time from the time of diagnosis all the way till someone's actually on their deathbed. And it's for anyone with a curable or non-curable condition. I think there are a lot of misconceptions about palliative care. I think people think it's only for people who are elderly or people who are actively dying.
Yeah,
or hospice.
I think it's at the very end, but really this is an issue of comfort, right? Of comfort, of care, of nurturing in a place where people are struggling.
Absolutely. Absolutely. And it's really focused on symptom management. Some of those symptoms are physical symptoms. They're pain, their shortness of breath, and other things that we think of as symptoms. So we're trained, specially trained to treat those symptoms. But there are other symptoms. Loneliness, depression from the situation that they're in. And we have an interdisciplinary team, and we all work together to optimize these outcomes and quality of life for this patient, depending on whatever their needs are. And we work with the other physicians to help to come together with a cohesive plan, really including the patient as the front runner and honoring what their wishes would be.
Well, because I think that you can't discount that, right? I think as a general kind of just base understanding that people know that how someone feels about what they're going through is also important. We don't want to, measure it against the whatever medications or treatments they're getting, but if they're in a deep depression or if they're so exhausted by the fight, then that really can determine. I mean, if you take someone on a ventilator, when we're talking about this, there's so much that goes along to it, not just being on the ventilator, right?
You are so right. And I have found through my practice, I thought, I went to medicine to help people. That's what I wanted to do. And I have learned so much from my patients and the families of my patients. I've been given gifts of knowledge that are invaluable. And I found that the question that is the most important to ask is, what is most important to you? That can give a physician so much information on how to come up with a treatment plan, where to focus, and really get to know your patient and what they want, what they need at this time. And it actually also helps the patient because it allows them to think about what their needs are right now and help us to focus more on what type of suffering, not just the suffering or discomfort, but what type, so we can really focus in on that treatment.
So what do you do with palliative? What is a typical type of treatment that you would employ in your specialty?
I wish I could say it was typical. A lot of it is definitely pain management. It's sometimes spiritual support, depending on what they need. It's social work support. A lot of times these patients have conditions that may not allow them to go home. And that's something that's hard for anyone to hear. They may not be safe in this because they have more needs. And then we may have to think about alternative methods for discharge. And that can be really difficult on the patient. So sometimes when we are managing someone and their needs, it continues to evolve and their needs continue to evolve. And we have to move along with that. Along with that, it can also be, like I said, frank symptom management, the shortness of breath, the pain, the medications, and other methods that we can use that aren't necessarily a pill you have to take or a medication you have to take through an IV. And including the family, as long as it's okay with the patient, including the family and the caregiver in this discussion, because they're the main person that might really be carrying out what we are discussing and teaching in the hospital and educating and empowering about. The caregiver at home may be the one that has to carry this out.
So how often is a palliative care doctor brought into a situation? I mean, at what point does someone say, you know what, I think you need to talk to Dr. Hamilton and figure out how we can manage this other part of your care?
So it really varies, but from the time of diagnosis of any life-limiting or life-threatening condition. And however that road lasts really differs from person to person. Some of these life-limiting conditions, for example, COPD, we're hearing a lot about that during COVID, right? Chronic obstructive pulmonary disease. It's something that someone lives with. Their lungs do not work properly, and it's something that doesn't necessarily have a cure. So we are treating the symptoms that go along with it. And so we're educating the patient. This may be something that you are going to have to live with, but how do we optimize the outcomes for you? Well, there's certain medications, the importance of coming to see your doctor and taking the medications at the right time, other breathing exercises that they can do, finding out what their needs are, and also really what I want people to really think about now, and it's a good time because we're all kind of quarantined together, spending a lot more time with our loved ones, is I want everyone to think about every healthy or not adult should have what's called a surrogate medical decision maker. It's called something different in different states. In New York State, for example, it's a healthcare proxy, but it's a medical surrogate decision maker. Any adult who is of sound mind makes a decision of who they would want to make medical decisions for them if at any time they were unable to make those decisions. So if I were to get into a car accident and for 3 days I was unable to speak for myself, they would be able to know exactly who to call and exactly who I trust to make the decisions that I would want.
You talk about a car accident, and that certainly is something that is unexpected. It happens immediately, but with COVID-19, that feels like what's happening to people who are very sick. You hear these stories, they woke up with a fever, and then 2 days later, this horrific virus has taken their lives. And so I guess in a sense, we should all, I wonder, are those that we can, print out online and do that? That's what you would suggest that we all do.
Yeah, I think that's a great idea. You should go to your state government website because it does differ by state. If you are working with a doctor, you can speak to them about it. They can put you in touch with the social worker, or the doctor themselves can give you the information. You can contact me if you need to, and I can help to give you some links. The American Association of Hospice and Palliative Care Medicine should be able to help, and the NHPCO, the National Hospice and Palliative Care Organization, would also have some information. Start with your doctor and your government website. These are also called advanced directives. It's a constellations of kind of discussions and decisions that we would follow. For example, in New York State, if we did not have a healthcare proxy form, or if we did not have someone that you chose to make medical decisions, we follow a hierarchy of medical decision making. We follow something called the Family Healthcare Decision Act, and that, for example, I'm using New York because it differs by state, but New York, for example, if you didn't have a healthcare proxy or a medical surrogate decision maker in place, it would be your domestic partner or your spouse. If you don't have that, or if they're unable, then it would be your adult children, and then your parents, and then your siblings, and then unique to New York State is anyone that you could find. And some people don't want their spouse making those decisions. Some people don't want their parents having to make those decisions or even know certain diagnoses. So it really empowers you to make that decision. You can change it at any time, and it only comes into play if you are unable to make those medical decisions, never before.
Yeah, that's important to realize. I want to get specific to COVID-19, though, in terms of palliative care as well. The heartbreak of, well, there are so many heartbreaks associated with this virus, but one of them is the story of, when someone goes in and they test positive and they are in grave condition, or they are in very serious condition, they're alone in this. Their family members don't see them again. I mean, that's what they were saying, be careful in terms of if you have a pet at home or you have children at home, like who is going to take over in case you get sick. And then, where I would think you normally would come in and talk to these patients, that can't happen as well either, because we're all limiting contact. It puts it in a horrible situation, and it turns it into this, like, where I can't even wrap my mind and my heart around the family members who can't be with their loved ones, and their loved ones who are alone and scared. How does palliative care work into that place to try to help?
It is so hard. It is so hard, and it's heartbreaking. And a lot of people who are contracting this virus, some of these are people that you would never expect to even be ill. So it's hard on the families, it's hard on the patient, and sometimes when a patient is on a ventilator, they're unable to communicate for various reasons. So the doctors are more overwhelmed and overworked than ever right now.
Hmm.
And with this social distancing and not even be able to be close to the patients or the caregivers, it's really challenging. What I would recommend for the physicians, I know we don't have a lot of time in a day with everything that's going on, but if you see your patient, to it's very important, even if it's a short time, to say hello to your patient, to update them on what's going on, and to absolutely ask if they have any questions. And doing that more frequently is more meaningful than necessarily standing it. We can't stand in a room. We can't spend as much time as we thought. Doing that more frequently strengthens the fabric of that relationship and really creates a trusting relationship. And it allows the patient to evolve with you. So as things are evolving, you guys are moving together in this plan and with the what ifs and the what might be. And that in itself is comfort and it's strengthening. It's not ideal. None of this is ideal, but it would make a huge difference. And in the same way, the medical decision maker of that patient, either designated by the patient or if the patient cannot speak for themselves, to have maybe make a phone date with that caregiver, to have an update and tell them, this may not be as long as I would want it to be, but I wanted to check in. And that would make a huge difference.
Yeah, there's a disconnect in terms of care just on the basis of the sheer numbers of people coming in with this, as well as the way this is happening and the inability. Normally doctors get to talk to loved ones, and I someone posted something on social media the other day, and I was hesitant to, repeat social media posts because you don't know the validity behind them, but it was allegedly from a doctor who was caring for a patient on a ventilator,
Mm-hmm.
and the family member called and called and called, and the doctor was so busy and couldn't stop, and they said, well, you just, and the person was on a ventilator, and they stopped and finally just put the person on speakerphone so they could do a prayer, for their loved one. And in the post, the doctor said, I didn't realize how much strength I got from that as well. And I think and you can correct me if I'm wrong, but the palliative care is for the patient, is also the people around them benefit. And in this case, when the doctors see so many things, it helps them, I would imagine, as well.
I have seen that in my own practice. When we have these meetings, and if it's a team with myself and another physician, sometimes it's a conference room full of many physicians and family members and family members' friends, and we are dealing with a lot of different emotions, a different lot of concerns, a lot of different questions.
Yeah.
But I have noticed that it's been a blessing, that we can leave the meeting and there was some togetherness. We were all on the same page and we supported each other through something really difficult
Yep.
without losing sight of who the most important person is, the patient.
Yes. Are you doing a lot of telemedicine in terms of how you are able to reach out to patients, and are you are palliative care doctors even getting any COVID-19 patients to help assist with that care? I mean, how, or has that kind of fallen, in a little bit off the chart in terms of when we're triaging and we're just trying to get enough masks and enough ventilators that
Right.
ideally, yes, a palliative care doctor would be great, but we're just, I don't know if we're there.
Never at the cost, of course, at the safety of the physician or the patient, but as much as we can to get near the situation. I can tell you in my own practice, I made rounds in the intensive care unit because it was likely at some point, regardless of the cause of them being in the intensive care unit, and likely now, most ICUs are completely filled with COVID patients, that I would make my rounds to see who needed me. And I'd speak to the doctor in the ICU and I'd say, how can I help? But generally that happened very rarely because I'd usually get a call ahead of time to come see patients, just like any other consult, a heart doctor, a kidney doctor, a palliative care doctor. I'd
Mm-hmm.
be called for a consultation to see them as an inpatient. But if there's not enough protective equipment, never at the risk of, again, at our own safety or the caregiver or the patient, but making a lot of phone calls, have a lot of phone numbers, even if it's not telemedicine, a lot of phone calls to the patient's family.
How are those received? Because I imagine, we're all feeling on these little mini islands wherever we are in our worlds. Um, when they get a call from anyone helping them, giving them some space, I can't imagine how comforting that is in a very scary time.
It is. And, I really take my time. I don't put time limits on phone calls. I don't put time limits on questions, whatever they may question. And I tell them, when we get off the phone today, you're going to think, I should have asked Dr. Hamilton that. I should have remembered to ask her that. I said, write it down. You'll think about it in the middle of the night. You'll think about it when we get off the phone. Write it down. And let's make a date for me to speak to you. Unless something happens more emergently that I need to make that phone call, I keep a phone date with them. And we address the situation. I update them. We talk about what their concerns are and any new questions that they have. And it's really comforting for them. The situation itself is really painful on its own. But I think for them to know that someone is really involved, really cares, and is caring about every detail about what's going on and caring to update them, it gives them some comfort and some involvement in the situation. They don't feel like an outsider.
Yeah, which is so important. I wonder what advice you would have for people who, because we're kind of in this world where even if someone tests positive, they have no symptoms, they're isolated, they're self-isolating, they may be watching things. And so the at-home care for someone in a family who may not be showing symptoms yet, but the fear always is, what if it gets worse? And how does that person self-isolate in a way that protects all their loved ones? How do we do that? How much, I would imagine that's kind of a new space in a way that palliative care can be really helpful in
It
those
is, and
uncertain times.
it's really scary because, as you know, there are many people who get COVID-19 who are asymptomatic or have mild symptoms. But we're hearing all these things because there's a huge range of the response to the disease and the condition that it can be really scary. You can wonder to yourself, could that be me? And it's a very scary space. I want everyone to just take it kind of moment by moment. Really do self-check-in, see how you're doing. If it's a fever, stay on top of that. If you're getting worse, I want them to not be afraid to take action and call their doctor. Because if they have a fever and they're getting better, that's a good sign. But if at any time they're worsening in any way, or staying status quo is one thing. If they're staying status quo for a few days, we can lean into that and see how they're doing. But if they're worsening in any way, if they're feeling shortness of breath, to not really wonder, oh, I'm feeling short of breath, let me see what will happen. Call the doctor the first time you have a symptom like that.
Yeah, and there's so much to think about in terms of how do you think this virus, and will it change the world of palliative care moving forward as well too, in terms of maybe just the need for more palliative care doctors, maybe a different way that we look at the services that you have provided, and when people need to be able to benefit from this?
I would say yes to all of that. With this COVID-19 happening, things are happening so unexpectedly. Families and patients are having to make really difficult decisions under really stressful conditions, and doctors are facing things they didn't expect to face. So I do say yes to everything you just said. I think there will be more attention brought to palliative care. I think there may be more use of palliative care. I absolutely think we can use more palliative care physicians and implemented early in a condition. I think, like I said, a lot of those misconceptions, people think it's consistent with death or dying. That's not the case. So if you implement palliative care early, it's an extra layer of support for the doctors, for the staff, for the patient, for their caregivers to get through this. And the earlier you implement it, the better. Because especially with something like COVID-19, we don't necessarily can't necessarily predict the road that it's on. We always hope for the best, but we want to be prepared, and we want to implement a service that is really useful and helpful. Even things like talking to the caregivers and help them make decisions like certain medications, certain interventions. What does this mean? Helping them navigate through the pros and cons of what the patient of these certain interventions and what the patient might want. asking questions and doing a lot of active listening can only help.
I know it's so hard. These uncertain times make, but I think you have been in a field where there's a lot of uncertainty, and so um, hopefully that helps us navigate through in the best way we can.
That is my goal. That is absolutely my goal, to help as many people as we can, uh, and to work together to really optimize their comfort in every way that we can.
Yes, we can control the things we can control, and unfortunately, there are so many things we can't. Dr. Suji Hamilton, I appreciate the insight and the perspective. It is important. I think the advance directive that you talked about, certainly none of us like to think about. None of us like to put the will together or our stuff in order. And unfortunately, the world we live in is in a different place, that if it should have always been a priority, but now I guess more than ever.
I agree with you 100%. I just appreciate you giving me this opportunity and taking this time to interview me, and for us to have a chance to really talk about something that's so important.
Yeah, so important, and I hope it helps so many more people. Thank you so much for all the work that you're doing and all the comfort that you provide. It is so needed in this scary time. It has always been needed, and I think now more than ever. Thank you,
Thank you
Dr.
so
Hamilton. And of
Thank you so
course,
much.
we'll put more information on coronavirusnow.com. Thanks so much for joining us.